All right, good afternoon, everybody. My name is Alexander, and in the name of PD, I would like to thank you all for your participation to this very first webinar hosted by PD. Thanks in advance to ask all your questions at the end of the lecture. Take the short survey after the lecture. Follow us on Facebook, of course, and create your MyPD account on www.pd-dental.com to enjoy more webinars on demand. Now I leave you with Dr. Marc Kaloustian and Dr. Marc Habib. Enjoy this webinar and see you a bit later. Thank you.
Hello, everyone. I hope you are all safe and ready for the scientific meeting. It is our great pleasure, Marc and me, to present this webinar, and we want to thank, of course, our friends from Produits Dentaires, Nicolas, Alex, and Benoit, and of course the audience that we hope you will enjoy this presentation. Today's topic will be mainly about two essential steps of the endodontic therapy, the cleaning process and the three-dimensional filling. As we discussed during the preparation of this lecture, the subject is very trendy and interesting, and we will try to summarize it in about 45 minutes with an overview of the important key points of the therapy. What do you think about that, Marc?
First of all, hello, Marc, and let me also thank the organizer and all the friends who are watching us. And regarding the topic, the main idea is to associate for once the cleaning, not with the shaping, but with the 3D obturation. Of course, the three branches of the clinical endodontics are completely related. But let us consider for once that the canals are already shaped with any system present in the market, and we need to do the disinfection and the seal of the anatomical complexity of the tooth, to have a tooth that is functional with no pain in the patient mouth on the long term.
Very true. I think we all agree as clinicians that mainly our aim is not the aesthetic of the treatment, but the outcome. We are going to keep them functional in the patient mouth as long as possible. Unfortunately, studies are very encouraging. Torre Benjad, for instance, talked about as high as 97% of survival rate in the primary treatment. And before him, Schilder was very confident also about the outcome of the therapy that we provide in endodontics.
I am very glad that you talked about the survival rate, which is also the clinical success rate. If we look to this Fernandez article, very interesting article, on a 10 years follow-up, we can see that the clinical success rate, which is survival rate, is 96.3%. But this means that the tooth after root canal treatment is still present in the patient's mouth without any symptomatology. But if we look at the x-rays and to see if there is a pathology or not, if we take a simple x-ray, we will see on the simple x-ray after 10 years follow-up that we have 89.3% of healing. And on a CT imagery for the same teeth, we have a 72.6%. This means that the clinical survival is not exactly if the tooth is, has no problem or not. But it means also that the tooth is still present in the patient mouth, so we can do any reintervention like a non-surgical retreatment or a surgical retreatment to keep the tooth. So we are far to go before the extraction of the tooth. At the end of the article, the author stated that what is important is the standards that we are working on, meaning the disinfection of the gutta percha, the finding of missed canals, the age of the patient, the treatment sessions, and the density of the root filling. So what is very important for us is to follow simply some standards. One of these standards is for example, in the upper molar, to clean the decay for this upper molar. We remove the crown, simply clean the decay, do a simple root canal treatment, and then we will do a follow-up after placing the crown. And we will see after 6 months that we have a complete healing of the lesion. On the lower cases, we can see a very large lesion with 2 necrotic premolars, large canals, easy to prepare, easy to disinfect, and to fill in 3 dimension. You can see 2 small lateral canals, and magic, after 2 years, we have the healing of the lesion.
I think that a 3-dimensional approach all along the endodontic procedure is one of the keys of a good prognosis. The canal is not a simple space to open and fill. It is necessary to treat all the aspects of the morphology from the orifice till the apical region. Like this case of upper premolar with mid-root lateral canal. Here we wait and we observe the histological process taking place over the years. Sometimes healing takes time, but we are known as endodontists for our patients during and after the treatment. For this premolar, we have complete healing of both lateral and apical lesion after 2 years follow-up.
Yes, actually, this looks very simple. The funny thing is that clinically, our treatment is very straightforward. We have 3 words: shaping, cleaning, and filling. But behind these terms, there is a word, and that's create the beauty of endodontics. And we believe that this is why we are always so enthusiastic when we achieve great results, like these 2 cases that we are showing done, one by me and one other one by Marc.
In fact, we share this same enthusiasm with thousands of endodontists all over the world. And that is why we are so happy to be part of this great group of Style Italiano Endodontic with gold members, of course, and our colleagues, silver members, and all the people that have the passion of the endodontic discipline.
Absolutely. We share the passion because we have all the same objectives as the masters and the colleagues of the discipline. Even if we disagree on some points, and we can discuss them about them, of course, at the end of this lecture. What we know that we need to shape the canals to achieve the biological objectives, and this is for the shaping part. We still have no choice for the shaping part to follow the old mechanical concept of Schilder. This is the key for us to clean without harming the anatomy by any canal transportation or worse perforations or any other iatrogenic issues that will lead to tooth extraction. But still, there is always a difference between the ideal that we have in mind with this beautiful figure prepared by Marc on the left and the reality with the micro-CT reconstruction of a real tooth mandibular molar that we did. We can see that even after a mechanical preparation with the best night-eye files and the best sequence, many variations that we need to take care of.
Then we can agree here that the cleaning plays a major role that we should not neglect, and that we need a protocol for it. Using a good solution with adequate volume and time, the best delivery methods and activation to be able to eliminate as much as possible of debris, bacteria, toxins, and biofilm before the obturation. As far as we know, till now, the gold standard is the use of sodium hypochlorite because it will dissolve the organic tissue and will play a major role in the disinfection. Is the concentration important? Most probably. But what is more important, according to this publication by Siqueira et al., is the continuous refreshment of the irrigant solution to maintain its disinfection ability. So what we need to focus on is the volume and the time. That's why a quick treatment leads most of the time to errors and failure.
The problem comes from the great efficiency of the shaping treatment. Treatment became very fast because the biological objective can only be obtained by combining the dynamic of the mechanical shaping and the chemistry of the solution that we will use. The good choice of this solution is mandatory. Sodium hypochlorite will assure the disinfection and dissolving of tissues. Chlorhexidine, for example, if you want to use it, has a poor dissolving action, and its use with sodium hypochlorite, as you know, is problematic. And on the other hand, it is an evidence that we need to remove the smear layer. For years, we use solutions based on ADTA, citric acid, and so on, with some successful result. We have nowadays in our armamentarium also a new product, the BioAct, which is nice because it is ecological and it is based mainly on silver citrate, which is a disinfectant. Combining with the power of the disinfection of this and the removal of the smell layer, we have also a very good sealer penetration according to this article by Tonini and al.
Very, very promising indeed. But the concept behind the solution is not only the action of this absolutely non-toxic molecule, according to the inventor, but also the protocol that emphasizes on a long period of cleaning and disinfection at the end of the treatment. So here we will have an equal time to the shaping, an equal time for the irrigation as for the shaping time. And that way, the canal will be prepared for obturation in a disaffected environment.
This final irrigation with BioAct after sodium hypochlorite rinsing all along the treatment was tested on this upper molar and delivered in all 4 canals with this needle. And we'll talk about this needle with details during this presentation. A final rinse with distilled water at the end is applied, canals are dried, and all the treatment, like in most of the cases, are performed in a single session, even when we are working on a 4 canal number 7, upper number 7. This will lead us to talk about the delivery method of the irrigation solution. Traditionally, we were using non-tapered side vented needles, but the problem with these needles is that they are not flexible because made from metal, so impossible to penetrate smoothly in curved canals. Also, they are not bendable, making them difficult to access in the canals of posterior teeth, such as of the mesial canals of upper and lower molars. Other issues were the narrowness of the needle, obliging the dentist to exert much more pressure to have a good flow of the solution of irrigation. Well, the new Irriflex needle has overcome these several issues. Can you please describe it for us, Marc?
Yes, of course. This new needle design is made of a flexible polypropylene with 2-sided vents, 30G at the tip and 4% taper, which will allow a smooth injection without any need of excess pressure. It has a full length of 27 millimeter long with depth marks at 18, 19, 20, and 22 millimeter, which will lead us at the depth penetration while doing the irrigation. It has a standard lower lock connection. As well, it has an angulation of 60 degrees, which will enable us to reach more difficult posterior. According to fluid dynamics, turbulence is characterized by chaotic changes in the fluid motion. It is in contrast to the laminar flow of a regular needle, which occurs when a fluid flows in a parallel layer. Irriflex soft propylene makes the needle curve and flex easily to follow the root canal anatomy, like in this simulation, showing a better penetration of the needle inside the main canal, distributing irrigant evenly everywhere. In fact, the back-to-back 2-sided vent design delivers more safely irrigation solution close to the apex, and the turbulence will create a shear effect, removing more debris.
Clinically, the sensation of irrigation completely changes indeed because of the feeling of security and the flow of the delivery, as you can see on these different cases done by myself and Marc. The breeze comes out very easily from inside the system, and we are absolutely don't need to enlarge taper canals to penetrate as far as 2 millimeters from the apical foramen with safety. You can see in the upper molar, on the lower left, long canals with only a 6% taper securely irrigated with this tip. And if we have a deep split like a premolar, the upper lower premolar, it is possible to bend the tip, the needle, which is not possible with the metal needle, and to go inside the 2 orifices easily without any problem.
This is for sure a great tool to add to our cleaning methodology, but the passive delivery system are not capable alone to optimize the cleaning according to several studies. That's why negative pressure techniques or finisher files, or also activation with sonic and ultrasonic passive devices that you see here were developed. This review of literature by van der Slaus et al. Showed the efficiency of passive ultrasonic irrigation with frequency above 30,000 Hertz as a supplementary approach in the cleaning process.
This is actually a reference article, Mark, and I like it very much. And you know that every year we have more publications that confirms these findings. The review of Verdi and al. About many supplementary approaches such as negative pressure, sonic activation, PUI concluded that all of them improve the cleaning ability and debris removal without a clear difference between the techniques. On the contrary, Habt and al. Demonstrated a better action of endoactivator and eddy on PUI on debris removal. Concerning the outcome, a very interesting systematic review of Silva and al. In 2019 showed that despite the certain cleaning efficiency, there is no clear evidence that activation can ameliorate the periapical healing. So this topic should be, in our opinion, more investigated in the future. But in any case, activation is a good approach and gives good satisfaction during the clinical work. Here is an ultrasonic PUI wireless device, the Endo Ultra. Ultra X is also a very good device that we can use. The small wire is inserted in the canal, but what is important is not to touch the walls, and this will create the acoustic streaming and the cavitation, and can also eliminate the vapor block. You can see, I think, the waves created by this PUI energy on this tooth. And at the end, we can see also lateral canals that were obturated during our 3D filling.
In this case, after using the Reflex irrigation needle, I used eddy, which is a sonic device working at 6,000 Hertz, with very good reviews also in the literature. Eddy's frequency is less than the PUI, but it can be compensated by a larger amplitude of the tip. Look at the movement created in the solution, activated 2 mm far from the apical foramen. The other advantage of the device is a complete passive action because the tip is not made with a metal wire. And this is the clean aspect of the access cavity after irrigation and activation. And this is the final result of this case.
These activations or finisher files like XP Endo finisher also are efficient in retreatment, removal of material. On this molar, first of all, we used the Reflex, and you can see that the Reflex is removing lots of GP remnants from the wall after the mechanical action of the instruments. And the activation was done with the MM1500 modified tip. We did actually a micro CT study about this tip and the eddy tip published in the IEG with good efficiency of both devices in removing remnants. The disadvantage of MM1500 is that the tip is, even though inactive and smooth, it is still in metal, so more investigation should be performed to see if it doesn't harm anything inside the canal. But now that we cleaned the canals with RESEF, with activation, how can we keep it clean like the day of the treatment for years, Mark?
Here you are asking me, Mark, about the longevity of the treatment. And for me, it's an important issue. The first question that the patient asks commonly after the root canal treatment, how long will the tool stay in my mouth? Well, longevity is guaranteed by the obturation of the shape and disinfected system. So we should simply do a filling of the root canal in 3 dimensions, as stated in the title of the famous article of Schilder. And this obturation have many techniques to be done like. We can use the one vertical technique, the one technique in general, the cold lateral technique, the bioceramic with the single cone technique. And they may all be okay. The important thing is to be able to achieve the best result possible, as shown here in the cases of both of us. We will talk in this presentation about the wound compaction technique because we believe in the concept and we want to show a method among other of 3D obturation.
Yes, Mark, we agree on this also because the wound vertical technique is a technique that we are using and teaching for years now, and we have a very good sensation and experience. And this experience is also based on the literature. Look, for example, at the adaptation of the material that we obtained on this extracted distal roots of lower mandibular molar observed under micro-CT after continuous wave compaction in the coronal portion, in the middle portion of the canal, and also in the more important, the apical portion of the canal. Besides that, for lower mandibular molar, Maloschi showed clearly that the mesial root of these teeth has an isthmus in most of the cases. We did also a micro-CT reconstruction of this root after obturation, confirming Maloschi's finding. We can see material penetrating inside the isthmus in some places and inside anastomosis. Hopefully, we will publish these results one day soon with Marc.
Beautiful, Mark. And moreover, the other aspect is, of course, the lateral obturation. And to be able to fill all these invisible lateral canals and anastomosis. And this study that we did using micro-CT reconstruction as well and 3D printing, we were able to reproduce and visualize fine details of the anatomy in maxillary upper molar. Another very interesting recent article by Zhu et al. Demonstrates large amount of lateral canals on permanent teeth and shows different configuration of this accessory anatomy, which can have an important consequences on the outcome. On the left side cases done by both of us, they show different types of configuration. We can have an apical location of a canal, lateral canal, or a medial position. We can have a fine diameter or a large diameter, and of course the number of portal of exit. We might have many lateral canals or only one lateral canal.
You are right to talk about this aspect, but what is the most important part is what we said at the beginning, the outcome. Many articles show no real difference between several techniques. It is true, but the huge amount of publications over decades proves that vertical compaction gives great results, so it is still a state-of-the-art technique. In this particular article, it even demonstrates its superiority over lateral cold compaction, for example, in cases where we have periapical lesion. If we look at this lower molar that I treated a year ago, we can see that after doing just a retreatment of this tooth, which has a very large radiolucency that cannot be contained in the X-ray because of its dimension, only after 6 months under temporary, we can notice the healing of the tooth. And to obtain this kind of result, we need to achieve a good vertical compaction. And to have a good vertical compaction, we need proper material selection, simply GP taper point. And this taper point, we will select them depending of the shaping that we did. We can choose the 0.4 taper point, gutta-percha point, or the 0.6 gutta-percha taper points. The good thing with this PD points is that we are able to combine the standardization with the different tips and taper. Before, in most of the companies, we use fine or fine medium or medium and calibrate the cone with a gauge. Standardization makes the process faster, and depending on the diameter of the preparation, we can choose the proper cone. The other important material, of course, is the sealer. This sealer, it is a zinc oxide sealer and eugenol liquid. The powder contains, the liquid actually contains the tea tree essential oil. This substance is an anti-inflammatory, natural anti-inflammatory, and has antibacterial properties that are very interesting for our treatment. And the second important thing when we are doing our vertical compaction or anything in endodontics is to have good ergonomics. Here, for example, we have this plano, And you can see that we can place the cones, which each cone is placed at its dedicated compartment with some disinfection material. We can place the paper point and, of course, the sealer that we will mist. And I was happy to take one day when I was in Milano a picture of the ceiling of the Plaza del Duomo at night, and I saw, and I said it to my friend Riccardo Tonini, I saw that it looks like exactly like the plano. So this is something fun. The other thing is that we have now the material. We have everything is ready, but we need to choose the good cone. So when we want to choose the good cone, we need to do the tack back. This is a very important article about the tack back on curved canal. They showed on micro CT that when we have a good tack back, they take a micro CT with the cone, and they saw that when you have a good tack back, you have a good fitness of the cone inside the canal. So this is something very important to teach to our patients. And here you can see on this small video how the tack back should be in the distal canal, and then in all the other canal, the mesial canal. You can place the cone, and you have to see a small resistance, only a small resistance in each one of the canals. After having the cone, we dried the canal. Now we have to mix the powder. The powder is added progressively to the liquid, as you can see, to have the proper consistency of vertical convection. Now, we can customize our mixing. If the canal is too large, we can give more thickness to the mixture, meaning adding more powder. And if it's thin, curved, we can give less viscosity. But in general, what we will need is a creamy consistency in most of the cases when 1 drop of liquid and 1 spoon of powder. Now I'm going to show you a case of a warm vertebral compaction clinically of a type 2 configuration on this upper molar. On this upper type 2, meaning that we have 2 canals that are joining. And you can see here, when I am suctioning the liquid from one, the liquid comes out from the other. And then we dried the canals, and we are placing the first cone in the MB1, and we can see the sealer in the MB2. This is another proof that these 2 canals are joining. And then we place the cone in the MB2. After placing the cone in the MB2, we can start to do our compaction, as you can see here. So what is very interesting by just classical vertical compaction, doing under magnification, is that we can see everything. We can see where to compact. We can see where to remove. So we don't compact the walls, and we don't have iatrogenic problem like fractures later on. We do, of course, first the MB1, the main canal, and then, because they are joining, we will compact the MB2. And at the end, we can do our backfill for both, because here you can see the backfill for both canals. And this is the final X-ray after the treatment. Another possibility is to use the continuous wave compaction. This article compared it with the bioceramic with a single cone, and it showed that the continuous wave compaction is equal to this treatment. So why do we like to do it more than the other one personally? It's because we have a compaction. So we can compact the material that we are putting inside. We will have less sealer inside the canal, more gutta percha, which is another concept from the single cone technique. So we are going inside the canal directly from the coronal part till the apical 5 millimeters, first in the buccal canal, and we'll just do a compaction at the end. We won't forget that in this technique, the plugger is also a heat carrier. So it does the heating and the compaction. And here we are going in the lingual canal, as you can see here. Very nicely, we wait a little bit, few seconds, because we don't want to have a retraction of product. We remove, and by removing, we will have some part of the material coming out that we will close it with the backfill by using an injecting technique. And here is, of course, after the compaction. You can see the case at the beginning. We had a lateral lesion on these lower premolars with 2 canals. And after doing our compaction, we can see some sealer coming out on these lateral canals, coming till the lateral lesion. And after 1 year of follow-up, even under temporary, the core material was placed, but there is still on temporary, we can see that we have a good healing, even though we have some extrusion of the material.
Vertical compaction technique was used as well in large canals for many years because it was the only technique available at the time. Like this case of a large central incisor with a good apical control. In these cases as well, done by Marc, where we have canals with bigger apical diameter going from 50 to 80, they are obturated in conventional vertical technique. But the problem is that the larger is the foramen, the more we need to give taper for a proper resistance shape. This will lead sometimes to fragilizing the root. So the whole idea is to adapt our obturation technique to the particular canal configuration, with sometimes large parallel canals, very wide immature apices with a V-shaped resorption, or teeth with iatrogenic errors such as perforation. So here, in the first photo, we can see that this case can be treated with a traditional worn vertical compaction. The second central incisor with large parallel canals can be obturated in a traditional way or with another material. And the 2 central incisors with very large apices, parallel and V-shaped, will be treated with another technique. For these specific cases, the introduction of hydraulic cement was a big revolution. It gave us the possibility to solve many problems. MTA is actually widely used in many clinical situations, cited in this excellent article by Core, like for pulp capping, pulpotomy, perforation, root end filling, root canal filling, and resorption.
Yes, Tul, and it is time to talk a little bit about the material, the MTA material. At the beginning, when we started using the MTA, the formula that we had was with the Pro Root, actually, which was a very good material. It was a Portland cement, 80%, and 20% of bismuth oxide as radio opacifier. The problem with this material was that there was leaching lots of bismuth oxide. So this bismuth oxide will result in tooth discoloration, which is very anesthetic, especially in the anterior part, in the anterior teeth. So that's why they started introducing other material. One of them was the Angelus MTA, which has less bismuth oxide. And later on, the MTA that we can mix mechanically by trituration, which has even a lower level of bismuth oxide in this material. But the problem is that this bismuth oxide gives the radio opacity to our material. So if we remove it too much, we won't see very well the material inside the canal. This is why the Produit Dentaire decided to remove completely this material, to not have discoloration, and to replace it by another, which is the calcium tungstate as a radio opacifier. Another important issue when we are using a material, sealing material, is the size of the particles. Look at this table. You can see that at the beginning, the size of particles were 58 microns. Then with MTA Angelus, we have a 12 micron size of particle. And the MTA Produit Dentaire, according to the manufacturer, actually has 6 micron size particles, which is very close to the biodentine of Septodont, which has 10 microns of particles.
So what's important, like for all MTA on the market, is to have a good mixture with a wet sand consistency to allow the repair material to spread easily and fill the defect space. And this wet sand consistency is needed as well for a proper setting of the material. This will depend, as stated in this article, on the water-powder ratio to begin with. And of course, the optimal way of mixing the cement is explained in many publications. Some are ultrasonically mixed, and other are hand mixed. For the MTA white, it is recommended to use the entire single dose powder and 2 drops of distilled water. The hand mixing shall be introducing progressively the powder into the water drops. Once we have the desired look of the wet sand, we can proceed with our repair.
After the mixing, we have to discuss, of course, about the clinical applications that we talked about earlier. Now, concerning the root canal filling, the technique of the apical plug is widely used since years. This is the apical plug of this lower distal canal of mandibular molar on a micro CT. This apical plug can be used on mildly large canals or very large canals, immature teeth, necrotic teeth, and it gives many advantages among other techniques. The idea is to place an approximately 5 millimeter of plug MTA to have a better seal compared with other GP techniques, mainly because with GP techniques, vertical techniques, or any other GP techniques, it is very impossible to create sometimes the hydraulic pressure without overfilling if the canal is too large. Can you please describe this technique to us, Marc, on resin tooth?
On this resin center incisor, after working length was recorded, we proceed with the drying of the canal space. Then the MTA gun was tested for fitting. It is important to choose the proper tip according to the case at hand. We should achieve the adequate depth to be able to secure finally a good apical plug. The MAP1 is used to inject the repair material in the apical third. We can see that the technique is easy to perform and is very much predictable, if you have, of course, the proper tools. After multiple MTA shots with the gun, we can follow with a gentle positioning or pushing of the material if you want. It's not a condensation with pluggers. We can use a micro brush if the canal is sufficiently large. Here I am using a large paper point, number 80, wetted slightly at the tip to be able to push and condense the material. Clinically, this technique gives us the possibility to treat this kind of resorption with an inverse taper and parallel canal with a very good control.
Absolutely, and even if we have larger canal, also with inverse taper, it is possible, like in this case, to use this technique. We don't need to do any shaping. We just need to do some disinfection because the canal is already very large. And obviously, in such situations, we need to place something to stop the MTA. So it will be a collagen matrix or a sponge. And this we will show it later during this presentation, how to do it. Besides that, to tell you the truth, it is even possible to place the material in not very large canals because we can't have dryness, for example, and some clinician, such as Terrucci, for example, use it in all his retreatment cases because he thinks it is a predictable material indeed. In this mandibular molar, the distal canal, we decided to experience this technique, was filled with MTA, while the mesial canals were filled with another technique. So you can see on this small footage that we are placing the MTA with the MAP1 plug, and then we are using a paper point, not very large one here, because the canal is not very large. It's a 55 paper point. And you can see how we did the plug here on this case. At the end, you can look at the final X-ray. One of the canals, the distal one, we have only the plug, and the dentist, prosthodontist decided to place a post there. And on the mesial root, we decided, because they were very thin, to use another technique, which is bone vertical technique. And you can see the difference of the radio opacity between the two techniques. In this other case, we have here a large canal. This 19 years patient came to us because of an old trauma. The tooth was necrotic. So we decided to place MTA. Here too, the MTA is placed map one system, paper points, and then we clean the walls here. This is very important step with a micro brush. So we will have a very clean wall and just an MTA plug at the end of the treatment. And here you can see very well the MTA plug. So after a second appointment, we will do the scratch test. Here we are doing the scratch test. We are making sure that the MTA is hard. And we want to do a backfill. So the backfill here was doing, like stated in this article, was a very good technique, which is the injecting technique. Here we are using the obtura 2 to do this injecting technique. We inject the gutta percha, and then we will do some compaction of this gutta percha. At the end, we will have this kind of treatment. So at the beginning, a very large canal. Then we take the length of the canal with a file. It is important to take an X-ray in cases like this one, because with apex locator, with large resorbed canals, we are not always sure of the accuracy of the material. So I just take an X-ray to make sure. And because we are not taking anyway an X-ray with a confit here also. And then we place our first plugs. Here again, if we are not very familiar with the product, it is good at the beginning of the cases to take an X-ray, but just to make sure that we attained the apical foramen, that you are not short. Okay. Here we decided not to use any matrix because we had the sensation of a good control in the apical part. We take the X-ray, we see that we are good with our lens of MTA. We don't need to remove it. We continue to place the MTA, and then we will place the backfill. The last X-ray, we have the MTA plug and the backfill with the little difference of radio opacity between the two materials.
I'm very happy, Mark, you brought up this point about the extent of the apical plug and if we should take X-rays or not during the apical plug. It could be short sometimes and it could be overextended. Sometimes the canal is just excessively large and managing an apical control is extremely difficult. Look at this case with the difficulty of controlling the MTA extrusion. Here, we didn't put any matrix. This was one of my early cases, and I thought that I was able to control the MTA, but clearly it was getting outside of the canal without me knowing. So the flow, the follow-up shows that the material is very well tolerated by the bone. So in such cases, what to do to prevent this issue? I'm going to show you in this upcoming case that I use another technique to be able to control the MTA extrusion. So in the following case, both central incisor were for an adult patient here with a history of trauma. Lesion and side-by-side sinus tract were visible clinically. CBCT imaging showed us the extent of the bone loss. After removing the old filling material, and we know this is a very difficult task in large canals where the gutta percha tends to be unreachable in some aspect of the canal space. I was able to visualize the huge foramen and the apical part easily under magnification due to the large canal and the big apical diameter. So in such situation, we have to manage an apical barrier, as we said, to make sure not to overfill and spread the MTA outside the canal space. I proceed here with blocking the root end with a collagen matrix in both canals. Once the matrix is positioned, I just push it more to the apical part to be able to visualize to be able to see if it is soaked or not. So here I'm pushing the matrix, and look, you can see that the matrix is getting soaked by blood. So I know it's at the desired position, and here I continue with placement of the material. Here, because the canal is very large and very deep, it is very difficult to condensate it and to position it properly, because the canal is very, very large, above 160 maybe in diameter. So a paper point is very difficult to plug it. After using a micro brush to position it very well, this is the final result, and 2 weeks and 6 months follow-up. And this is the photos and X-ray of the full case. MTA is also a great material for perforation repair. It might significantly improve the prognosis, but the outcome of this kind of repair depends on several factors. Most importantly, the location of the perforation, which could be in the furcal area or in the canal. Also, the time between the perforation and the repair is essential. The diameter of the perforation is an important factor as well. The obturation technique and the final restoration. And finally, and most important, I think, is the experience of the clinician. So ideally, the best outcome would be an immediate repair of less than 1 millimeter furcal perforation done by an endodontist. Also, I would like to share with you this very interesting article about published by Kingsland in '89, an old article, but very important. He cited in his findings that 53% of the perforation were cases done by the prosthodontic after prosthodontic treatment, and were done after post-preparation. So this case of an iatrogenic perforation due to a wrong axis drill for a prostopose. After dismantling the amalgam and the post, we can see that the perforation is in the mesial aspect of the palatal root. Here I proceeded with the preparation and obturation of all three main canals, and went to prepare the filling of the perforation at the end. Here, we didn't use any matrix because clearly we can see that the perforation is small diameter, although the axis was a bit difficult, but it is nevertheless of small diameter. So with difficult axis, we were able to position the MTA and condensate it with a microbrush. So once it is very well positioned in the perf space, we go ahead and we put a cotton pellet soaked with water to be able to keep humidity above the repair. And here we reschedule another appointment for the patient after 72 hours. It's important for the setting of the material. After 72 hours, we can recheck the setting of the MTA using the scratch test. And this is the full case, the access cavity before and after perforation and treatment, and the X-ray before and after perf repair. This is another referred case as well with iatrogenic perforation. This case is only to illustrate that the technique and the material can lead to a favorable and predictable outcome. Here, after retreating this premolar and doing the final obturation, we go ahead and do the perf repair. After 15 months follow-up, we can see that the lesion has healed, and facing the perf repair, we have a very good aspect of the bone and without any symptoms.
Very nice cases, Mark. And looking at the perforation, you mentioned the dimension of the perforation. I think we should look a little bit at this article done by Gorni et al. In 2016, talking especially about the prognosis of the perforations. And here too, they say that when the perforation is more than 3 millimeters, very large, the prognosis, of course, decreases. But sometimes we have in front of difficult situations where the patient wants to keep really his tooth, and he says to the dentist, let's give it a try. So the patients know that the prognosis is maybe not very good, but we try to do something to keep the tooth before the extraction and to put an implant. This is an actual case, a very difficult case of a retreatment, because it's difficult because we have several iatrogenic problems. And we have cases like this one. Sometimes we look at them and we don't know exactly what to do. We have to take every problem and to see how to solve it. First of all, we have perforation. Why we have a perforation? Because we have an old fiber post placed there. And the dentist tried to remove this old fiber post because it was broken in the coronal part. And he used a Gates Glidden or a piezoremer, I think. But instead of going inside the fiber post, and this is a classical error that we do, he went laterally. So he did inside the canal a lateral perforation. So the case was sent to us. And first of all, we looked at other problems also. We saw that in the palatal canal, we have a short obturation that we had to remove, of course, to have a good prognosis of the treatment. And also, we have in the mesial canal a large lesion. And why do we have a lesion? Obviously, we have a lesion because we have, of course, a missed canal in this mesial root. So the first thing we did is to remove the fiber post, the old fiber post. Of course, this should be done under magnification to be able to see the fiber post. So the fiber post was removed from the canal. And then the perforation material was placed after placing the obturation after doing the obturation of all the canals. We used the MTA material here because we think that this material is a good material, and according to this article of Siouf and al., very good article, we have better prognosis with it is MTA than any other material used for this kind of perforation. We are using a collagen matrix here, sponge, and then we are placing, you see, it is very easy where it is done under magnification because we see everything. So we are doing some compaction, very light compaction with the paper points. And with the map 1, we are injecting and compacting a little bit also. We remove a little bit the excess, and then at the end, we will place this micro brush to have a good seal of this perforation. You can see all 4 canals, the perforation, and you can see the canal, the palatal canal that was also retreated in this case. This is the final X-ray showing the retreatment of the 2 molars actually. Number 7, we just did a normal retreatment with the warm vertical compaction. And on on the other one, number 6, we placed the MTA and we retreated all 4 canals. And this is the final X-ray after 6 months. The dentist decided to place a core material and to wait and see. But I think that we start having a resolution of the healing. We still need to wait a few months, maybe a little bit more, to be sure that we have a good healing of this treatment.
MTA can be used in many other situations as well. Of course, one of them is the best endo treatment ever, which is the conservation of the pulp vitality. And the MTA here is still the best material for pulp capping, as stated by this review publication. While cleaning caries on this lower first molar on an 11-year-old boy, pulp chamber was reached, and in some places it was visible by translucency of the thin layer of dentin. So here I chose to preserve the vitality and do a pulp capping since it was an immature tooth with healthy pulp tissue. Using the MAP 1 larger tip, the blue ring tip, to deliver a bigger quantity of material, I was able to pulp cap the tooth and rebuild it, as you can see clearly on this final X-ray. So we can see it's an immature tooth with the pulp capping and the final restoration. Also, on another extreme, where we have multiple treatments on one tooth, and finally, the only left solution is an apical retrosurgery, MTA is a great option here. In this article, a 10-year follow-up on 119 surgeries shows a higher rate of success. If we look at this case of lateral incisor with a long post and almost 50% bone loss, we know that an orthograde retreatment is a suicide for the tooth, and we might eventually lose the tooth. As you can see here clinically, the tooth is surviving without any aesthetic problem. And after probing, we have a healthy periodontum. But underneath it, there's a huge chronic lesion that has been eroding the bone and causing repetitive pain and swelling. So here, after removing the granulation tissue, we did the resection. And here I'm using a 6mm retro tip to be able to reach the post, because I prefer to reach the post and to clean the entire system and fill it, the entire system, not keeping any gap between the post and the filling material. Of course, after drying, we are using the MAP1 system and gun. And I'm doing a double shot at the beginning, double shot of MTA to give a good quantity of MTA. Then I'm condensing it with the retro plugger. Afterwards, I continue my shots. Once I feel that it's already very dense and condensated inside the canal space, I go ahead and I polish the case. And this is the final situation. So we have the pre-op X-ray and the post-op X-ray and all the stages of the case. You can see on the retro mirror how I was able to visualize under magnification and retrovision the post space and the post. Of course, an important issue is to take care immediately after the use of the MTA is to clean the map system to prevent any blockage in the tube. We can manage this, like in this short video, with the use of a super floss going through the MAP1 tube several times.
What is important also is to be able to treat most of the cases, and we should not forget our young patient also. Sometimes we have deep caries on primary teeth, like on this lower molar, and this is the everyday pulpotomy for pediatric dentists. This can be easily performed actually with MTA as an alternative to other traditional material. This systematic review concluded that MTA performed better than biodentine, formocresol, or ferric acid. So this is a very nice material. And here is the case of this mandibular primary molar. You can see the decay, and it's very important to do all the procedure, like everything in endo, under isolation. After removing the decay, we can see the pulp, the orifices of the canals. And we have still a slight bleeding. So we have to control a little bit the bleeding, but not excessively, because we know that MTA doesn't have any problem if we have some bleeding. And then we will place the majority of the MTA, in this case, with a spatula. And we will condense, not with a paper point, but with a gauze here, slowly. And in some places, to have the best seal possible, we will add MTA using the MAP1 system, as you can see here in all the cavity. We do a last check of the MTA. And in cases like this one, it is preferable actually to place directly the prefabricated crown to have a good seal from the beginning of the treatment. Now we are arriving to the end of our lecture. We hope that you enjoyed it. We showed a lot of cases, different cases. The idea was to show how to clean and how to fill easy cases, classical endodontics, large canals with MTA, perforations, and other iatrogenic errors. It is a little bit confusing, but at least it is not boring. You see that this woman from Edward Hopper painting, she is bored alone in his room. As endodontists, we want always to have action, and these cases will give us always this action.
So I hope that you had some action today, and as Marc explained, we hope it was useful and instructive, and would like to see if you have any question, and we'll be gladly to answer them. Thank you
very much. Thank you, Marc.
Okay, so let's start with the questions. I have here a first question. So the question is, did you advise to use 2% chlorhexidine solution as an irrigant?
Well, do we have the echo now, or it's okay?
No, it's fine.
Okay.
And I am muted.
Okay. Actually, chlorhexidine is a very good disinfectant. It is this is something sure, but the problem that it is not a good tissue dissolving. So we cannot use alone chlorhexidine, especially when we are working on vital teeth. So we need to use on vital teeth sodium hypochlorite. Sodium hypochlorite is still a must because it will dissolve the organic material that is inside the canals and has a disinfectant properties. So the best is to use sodium hypochlorite. If you use sodium hypochlorite and chlorhexidine, we will have a yellow tooth because of some precipitate chemical interaction. And so it is impossible to use them together. That's why what we propose is to use sodium hypochlorite and also to propose something to remove the smear layer. This can be EDTA, this can be bioact, citric acid, and so on. But what is very important is the time and the volume that we'll give to our disinfection material. I don't know if you have something to add on this issue, Marc.
No, I completely agree. We know that using chlorhexidine, we should rinse and clean.
It makes our job a little bit more difficult to use chlorhexidine on daily use. So we prefer to just keep it maybe for some specific cases where we want to disinfect more, and not to use it on continuous everyday use where we should every time rinse with distilled water after sodium hypochlorite and then use the chlorhexidine. So it's not very practical.
Here I have another question. Question is MTA versus biodentin, which is the better? Which is better?
What?
MTA versus biodentin, which is better?
I'm going to answer. Marc will give his input also. We know that there's many studies that compare biodentin to other products. We personally, we were working and we are still working on many studies concerning this topic. We know that biodentin is very good, especially in treating floor perforation. And MTA, today we know we have lots of experience with it, and we know what is the outcome with the MTA. In fact, there's no much difference between the two materials. We know that both of them, especially the PD white, the new white PD has, both of them don't have the bismuth oxide. So we know that we are ameliorating the MTA, and biodentin doesn't have the bismuth oxide as well. The particles, Marc talked about the particles. We have biodentin is one of the material that has very small particle. The new white MTA of PD also have very small particle. It's about 6 microns, and biodentin is about 10 microns. Marc, what you have to add to this?
Yes, I completely agree. The idea is that both materials are hydraulic cements. So if you asked Professor Camilleri, it's approximately the same material. But the difference is that in the biodentin, they removed the bismuth oxide and they placed zirconium oxide. So not to have this discoloration problem. And the difference also is in the liquid. The liquid is not only water. In the MTA, the liquid is only water. In the liquid of the biodentin, you have calcium chloride that would accelerate the setting of the treatment. Both materials can be used. It is, I think it is something related with the clinician who is working. As we said, we are MTA, in my opinion, is easy to handle if we know how to mix it. And if we have the good material, good small guns, it is really, really easy to use, especially when we have large canals to do apical plug, perforation. It is a very simple technique to use.
I will add to that also, because Marc talked about it. We have also the issue about the radio opacity. Biodentin is very much less radio opaque than an irregular MTA. And this is clinically, it's a little bit
Frustrating.
Frustrating because we cannot see it on the X-ray. We cannot see the limit of our product on the X-ray. And sometimes we need to know where is the material that we just treated. And this is also a plus in other products.
As I showed when I showed the apical plug.
Yeah.
You know, if you don't see the material, you are not sure that you really have the apical plug in the apical part of the root canal.
Thank you. I have another question. The question is, when using a paper point, doesn't the paper point remove moisture from the setting MTA, which is vital for its setting?
Yes, but we use the paper points to compact the MTA. But at the end, we are using also paper points with moisture, with the water of the MTA, to have the setting. So it's we use the paper point at the we do the alternation between paper point without water, because we want to have this small compaction, and then we alternate with a paper point with moisture. I don't know if you do the same.
When I showed the simulation on the resin tube with the apical plug technique, at the end I can show that I'm using a size 80 paper point, and I'm just tipping the tip of the paper point so that the cone will remain stiff. It will remain stiff, so we'll be able to plug a little bit with it, and at the same time it is wet. The tip is wet, so I don't think we have a problem on that one. Secondly, we described that at the end we put a cotton pallet with wet humidity, so we are sure that there is sufficient humidity after the treatment to be able to give all the time for the setting of the MTA.
I want to add something here. We know that the PD MTA and other MTAs also nowadays, they have a setting time that is very quick. This is very good, but as endodontists, we prefer to postpone to check again the MTA setting after 72 hours. I think this is something we wanted to say, because sometimes we have a problem with the setting, and if we have a problem with the setting, we can remove it and place again. If we do, for example, an apical plug, and on the same day we place the gutta percha on the apical plug, we cannot be sure 100% of the setting with any MTA that we are using. So it is preferable to place first the apical plug and then place some moisture on this MTA for 72 hours. The patient comes back. In most of the cases, we have a setting and we can do our restoration, our gutta percha, injection, and so on. I don't know if you agree on this, Marc.
Completely.
Another question, what kind of collagen matrix do you use?
I showed a case where we're using a sponge, and Marc showed a case where
I used the collagen matrix of the perio used to treat. I forget the brand, I have it. It's like a paper. It's a matrix, it's not a sponge. Because we have experience with the sponge, Marc and I.
It's complicated.
It's complicated. It will drop to pieces, and it's difficult to position. The matrix, as we saw in the two central incisor case, it's much easy to position and to visualize, and with very good results, I believe.
A question, do you still use EDTA gel during the preparation? Sorry, we don't hear you.
You hear me now?
Yes, perfect.
Personally, I am not using EDTA gel anymore in most of my treatments. Sometimes I use it when we are working on a vital tooth, just at the beginning, just when we are doing the scouting with a manual file, I use it, but just a little bit. Once I have the scouting, I switch directly to sodium hypochlorite, especially if we are using a needle like the Iriflex, because once we have the orifice enlargement with an orifice opener, something very large, the needle will go inside the canal very easily because of the taper, and we can have a very quick flow of sodium hypochlorite. What is very important in all cases is not to mix at the same time the sodium hypochlorite and the RC prep, which is the the glide, because it will have diminish the effect of the sodium hypochlorite. So if you want to use the gel, just
at the beginning,
use it at the beginning.
Yes.
Then you switch completely to the solutions of sodium hypochlorite, etc., etc.
And we want to put as quick
inside the canal. We want to put it immediately to give it more time. As we spoke, we want the time, the shaping time, to be as equal of the cleaning time.
Perfect. What is your technique to remove MTA from the root canal?
Sometimes, as we were saying, we want to put the wet cotton pellet for 72 hours, exactly to see that it is set or not. Sometimes it doesn't set, and maybe it's set partially, or it's not sufficiently hard on the scratch test. We have to remove it in this time. So in these cases, we use just ultrasonic when we can use the ultrasonic, but we don't have any other option to remove it. I don't know, Mark, if you have you use other thing to.
Yes, I don't know if they were talking about retreatment cases, or as Mark said, if we have we did place the MTA and we don't have setting. If we don't have the setting, it's easy because it is not set. If we are doing a retreatment, it is we don't have the choice but using the ultrasound, of course. But it is not very difficult if the canal is large under magnification, because the MTA is white, so we can see it very clearly inside the canal, if we are using magnification, of course. So we can use an ultrasound like the ET20, which is an ultrasound like it's like a spreader, so it is very thin, and we can go inside. What the problem is here about we can reach the apical foramen without any problem, I think, in cases like this one. The problem is the MTA on the walls. And this is the problem also with gutta percha, but it is bigger when it is MTA on the walls, or when it is bioceramic on the walls. How do you remove all this material from the wall? This is the difficult part. That's why we talked in a small slide. I hope we didn't have a technical issue on this slide. We talked about the additional approach that we are using. So we arrived at the apical part, but we still have on the wall some MTA, some biodentine, whatever. We need to do some activation. Activation can be done with ultrasound, can be done with, which is the PUI. It can be done with sonic instrumentation, or it can be done with finisher files. So we hope that this case to remove most of the MTA that are on the walls of the treatment. But MTA, it is cement. It is like Portland cement, so it doesn't have any solvent, so we cannot dissolve it. So we need to have a mechanical removal, complete mechanical removal of the material.
One other question: what material do you use to stop the bleeding before applying MTA for a root canal perforation?
For the root canal perforation, of course, depending on the situation of the perforation. For the pulp chamber floor, sometimes if it is a recent perforation, we might not need to do anything. We just prepare the canals and the bleeding will stop alone. While using the time to prepare the 3 canals, the bleeding will stop alone. If we need sometimes to postpone the session, also the bleeding will stop alone. If it's an old perforation, I don't think that we will have a bleeding, but we should keep in mind that we need the bleeding at a certain level, because we want the bone to be healthy. We don't want to inject anesthesia and much anesthesia and the perforation, because we want the bone to be healthy, to be able to receive the repair material, because MTA needs a healthy bone as a matrix also to do the setting, and the humidity also to do the setting.
I think that in most of the cases we can just do compression.
Compression, but
I personally I didn't have a problem
with the bleeding anytime.
Good. We have here another question. Do you recommend 5.5 or 6% sodium hypochlorite for retreatment? A tooth with a big lesion, for example?
Concerning the concentration of sodium hypochlorite, we showed the article concerning this. There is no it's controversial. So some people, they use 1%, some people 2.5%. I am personally using 6% sodium hypochlorite nowadays. But I don't think it will make, honestly, it's more a choice. I don't think it will make a big difference by using 5.25% and 6% sodium hypochlorite. What is important for sodium hypochlorite is three things: the volume that we are using, and the time of use of sodium hypochlorite. That's why we insisted in this presentation on the fact that we have nowadays a very quick mechanical preparations. In 2 or 3 minutes, we can prepare the canals because we have good instruments. But the time for the sodium hypochlorite, especially on vital tooth, and even if we have a lesion, the time is more than from 25 to 30 minutes. So the time is important, and the volume is important, and also the activation or the use of a system like the negative pressure. I don't know what is your thoughts.
No, we have the same.
Here I have another question. The squirting technique of obturation, how to exactly do it?
I show, can I answer?
Obturate.
Yes, I showed the obturator gun, which is the injection of gutta percha. In the case that I showed, I had the plug in the apical part. So we don't have any risk of extrusion because the apical part is closed with MTA. So we just go and touch the MTA. Okay, just there. We put some sealer on the walls. We touch with the needle because it's a needle with a gun. We place the needle on the MTA and then we inject. What the trick is not to inject in one shot, because if you inject in one shot, you will have some bubbles inside. So you have to inject, compact, inject, compact. So now if they are asking what is the technique to obturate the canal, all the canal with the injecting technique, it is really more difficult. Some dentists are doing it, like our friend Calogero in the Stato Italiano on Odontics. He just placed an article, a case about this. The difficulty here, of course, is the apical control. So how can you control the apical part? So we need some experience with this technique to be able to close all the canal with the injecting technique.
Another question, granulation tissue below the perforation, do you leave it or do you curette it? Sorry, Mark, we don't hear you.
Sorry. So if it's a granulation tissue, it's there because it's an old perforation. So if you have a granulation tissue, of course, it's better to remove it. But sometimes when you have a small perforation, which is about less than 1 millimeter, you cannot curette it from inside the perforation. When it's a big perforation and it's a chronic perforation, so we have surely granulation tissue, of course, it's better to clean it and put a sponge or a matrix with a contact with a healthy bone to be able to do a scaffold for the MTA. So if we can reach to clean it, of course, it's better to clean it. But if we cannot reach it, maybe we can only reach it from a surgical aspect. So we'll have to postpone it for another session or do the surgery before to curette it. But ideally, it's better to remove the granulation tissue. This will help with the healing and the outcome, of course, of the perforation treatment.
Perfect. In case of intermediate medication, which material do you use in the canal?
I personally don't recommend any intermediate medication. And in most of the cases, we are doing one session root canal treatment, except when we have swelling and when we have cases of apical periodontitis, very symptomatic. In these cases, of course, we don't do the filling at the same day. The only medication that we can suggest is calcium hydroxide. But the problem with calcium hydroxide is how to remove it entirely. because this material, if you keep it inside the canal, it will resorb with time. And if it resorbs with time, it will create some voids inside the canal, and you can have problems later on. Now, with the new activation systems that we are having, many articles are talking about the removal of the calcium hydroxide from the canal by using PUI activation, which is the ultrasonic activation that we showed, or sonic activation. So this can enhance the removal of sodium hydroxide. But I think the best to do, I used to say to my students when we used to go to the university, the best to do is
we don't go anymore.
When you are doing a surgery, do you keep it open? You do the surgery, you close everything, and you send the patient. The endodontics should be about the same, in my opinion. You open your system, you clean your system, you close your system, and even if you can do the coronal seal at the same session, it will be better. I don't know if you agree on this, Marc.
Yeah, I completely agree with you. We know in our practice that rarely we use, I use calcium hydroxide very rarely. I use it when we have like rebel cases with the lesion that doesn't dry. This is when I use it actually. If the first, always the target, the aim is to do a single visit treatment, we know it's better for the outcome. When we do a first visit and we know that we have a lesion and we have like pus going out or liquid, and we just make the shaping and we postpone for another session. If on the second session we still have liquid or pus, and this time I will add some calcium hydroxide, but as Marc said, the difficulty is how to remove it inside the canal, which is if the calcium hydroxide will go outside the canal, it will be resorbed by the bone, we know that. And the target of the calcium hydroxide is to change the pH of the canal and stop the acidity. It will rise the pH. So unless it's very necessary to use it, I don't usually use calcium hydroxide, but it is indicated in a few rare cases.
I think if you have pus inside the canal, I don't want to be controversial, but I heard this a long time ago also by Professor Castellucci. The best way is to keep the tooth open for a few hours. Even if you want to keep the patient in the office and keep the tooth open, most of the cases, the pus will go away. Now, some people will say, but if you keep the tooth open, the canal will be infected. But when you have already pus inside the canal is completely infected already, and you need to do, after drying the canal, a new disinfection session. So this is not a big deal. If you keep it a little bit open, the patient will not feel anything because all the pus will come out. Sometimes you can suction even the pus with microcannula. All the pus will come, can come out, and you can do even your filling without giving to the patient, because we don't like to do this, any antibiotic therapy, because we removed we had the drainage from inside the canal. Of course, not if the patient is really very swollen. If he's having a Ludwig angina, we need to give antibiotics. But in most of the cases, without any internal medication or external medication, we can perform our treatments.
One other question. Orthograde filling of MTA rather than retrograde MTA filling before periapical surgery. Which do you recommend? Marc, your mic. Yeah.
Yes, I'm answering. So orthograde filling of MTA rather than retrograde MTA filling. So here, if we have access to the apical part from the orthograde aspect of the canal, of course, we are going to do.
And then you do the surgery.
But sometimes we cannot reach the apex. This is why we are doing the surgery, because as we showed in the case, we don't have any way to reach the apical part with a lesion or with a bad root canal, so bad root canal treatment. So we'll have to go surgically immediately. Sometimes we have some cases where we start with a orthograde filling, and if it doesn't heal, we might complete the treatment with a retrograde MTA filling. So we are going to do it twice. But I believe the surgery is indicated when we cannot do an orthograde treatment.
Perfect, thank you very much. Any other question from the participants? If not, I think, yeah, let's wait 30 seconds more. Okay, so I think that we are done. Again, thank you very much, Dr. Marc Kaloustian and Dr. Marc Habib for the webinar and for answering all these questions. I personally hope to see you soon. And thank you for everyone who has participated, and sorry again for the echo that we had at the very beginning. Again, we will fix this and you will be able to review the webinar on demand with a better audio. So thank you very much and see you soon online.
Thank you.
Thank you, guys. Thank you,
Alex.
everyone. Bye.
Bye-bye. Thank you.
Ciao.